This patient was on a 100% NRB, non-rebreather. Can I do anything else for them, giving them 100% of oxygen? Yeah, how would I add the PEEP? Right, so I would initiate CPAP at that point. Right, guys? So we can go up to the, let's say this patient, the same patient was on a 50% venti mask. What could I do? CPAP or oxygen?
Oxygen.
Oxygen. What can I go up to? How much percentage?
We're talking 50. He's on 50% right now.
50% venti mask.
That's the
We can go up to not 70.
80.
Nope, not 80.
What's the
60.
whole?
Why? What's after? What do we look at when we're at the 60% range? Anything after that?
PEEP.
Yeah.
We want to initiate PEEP or CPAP because we don't want to run into O2 toxicity, right?
Yeah.
So you want to treat the patient with oxygen up until 60%. Then at 60%, you should be thinking to yourself, there should be something
60
else.
then PEEP.
Then
Or
PEEP.
CPAP.
Is CPAP the only way to give PEEP?
Oh yeah, for CPAP indeed.
Besides like BiPAP and the vent and stuff, but the first way to give
Yeah.
Okay.
I mean, I'm not going to sit there and back mask them with a PEEP valve, if that's what you're asking, but I mean, I guess you could.
No, mask on. Yeah.
But there's no
Walk
like.
away.
Yeah. So yeah, you would have to go then to the
Yeah.
CPAP device is the only way to give your first line of giving.
Yeah.
But like if your patient goes from like warm air to 60% and now needing CPAP,
It's not
you should be
invasive, so it's
questioning
not a big step.
what's
Yeah,
going
nothing
on.
to
Something has
CPAP, it's
changed.
just adding the PEEP. Yeah.
Let's get a
Or an
chest
inspiratory
x-ray.
pressure
Let's
too,
get
a
a
little bit.
sputum sample. How do their lungs
Intubation.
sound?
Ventus.
All these things you should be thinking of. Have they thrown a clot? How are they presenting?
So if you had someone on 100% and their PO2 68, what is that an example of? We were talking about a big shunt. Yeah. So you got issues. So you got to think about. So maybe they have fluid. That's why they're ventilating.
Yeah.
But just their O2 is your refractory hypoxemia.
So you apply
Okay.
PEEP.
Yeah, because you are adding the 100%. There's nothing. It's ventilation, but it's not getting through. So what's in there that's blocking it? Is it fluid from a pneumonia? Is it fluid from CHM? You know, what's going on in there that it's not making it across so that, you know, the person cannot oxygenate. I mean, yes. No, because, yeah, ventilation, no perfusion, a clot or something.
If they had a sudden clot, would it be very painful?
And that's, like a pulmonary embolism usually isn't painful. There's not really any, like, type of nerve.
I know when you have one in your leg, it's supposedly painful.
Oh, yeah, that's, it's blocking like a figure, but like the pulmonary, I mean, you could get a little, I guess people have said they have some chest pain, but usually it's just their sats are down no matter what you do. And you put them on 100%, you put them on BiPAP on the 100% FiO2, and they're still kind of low, and that's when you know that their AA gradient is not good. There's something, and then they have to go for like a scan or something, because you're suspecting when you're giving someone everything and their sats are still low.
You may have to intubate even if it's not a ventilation problem, because there's hypoxic respiratory failure. So, and you may not learn that necessarily in school because you always learn, oh, ventilation goes directly with the CO2.
Yeah.
But in the real world, if you have someone on CPAP of 15 with 100% and they're not oxygenating,
And their sats are still in the mid-80s.
you gotta intubate them.
Because you can only be hypoxic for so long, and you're going to go out of the picture.
Right.
So it's better to do it sooner than later, because you know that all these things, it's a domino effect. You're starved for oxygen. You can only do that for so long. You can only hang on for so long with no oxygen.
Before you're having a house brain injury.
And that's like 3
and your heart's
minutes?
going to take a hit, and your brain's going to take a hit.
3 minutes with not breathing, like
Completely.
But can your heart maintain at a sat of 85? Well, maybe your chronic CO2 retainers who are like used to it.
Not good though.
But I'm
You need
talking
to
maybe like
step on it a little bit.
70%. Can your brain, can your lungs, can your heart, can your organs really live at a SpO2
Not
of
good.
70%? For how long before you start having tissue damage, brain damage, tissue damage to your heart before you have a MI or what have you.
Ischemia, that type of thing,
Right.
yeah.
So
And your heart's gonna be working real hard because it
found out
knows
that
that
it
your
was a
body's
shunt
not getting
because you're
enough
giving the
oxygen,
O2
so
and
it's
nothing
gonna
was
pump
happening.
faster.
Then what? You know it's a shunt because you're giving 100%
So you're
oxygen
getting
and
working,
nothing's
so they need to
happening.
go to the ER,
And
get
then
a
I've
scan,
initiated
as soon as they get in
CPAP
the
as
door.
well.
Yeah.
And if
Find out
sats
what
are
the
still
problem is.
70, I'd be intubating them.
Okay, oh, then you would just intubate and
But
find out
I
where
don't
the
know,
shunt
like,
is
you know,
or
as far
try.
as like school-wise, if that's what they're gonna teach you.
I
Just
know.
know that, you know,
We just put them on
CPAP's for
CPAP.
Yeah, at this
oxygenation,
point,
BiPAP's for
CPAP.
ventilation.
Backs against the wall, yeah.
So now you have a patient on CPAP of 10, 60% FiO2, blood pressure is normal, but sats are only 87. What do I want to do? Do I want to go up on the FiO2 or do I want to go up on the CPAP?
FiO2?
No, you're
No.
at 60 because you're at 60.
60.
Yeah.
60 is the
Oh, yeah,
magic
yeah.
number. So let's go up on the CPAP, okay? So now we've gone up to a CPAP of 12 centimeters
You said it.
of what? And we're at 60% FiO2. Guess what, guys? Stats are still 87, but now your BP is 60 over 30. What happened? What happened? I increased the CPAP to 12.
Is it
Yes, so we became hemodynamically unstable, our blood pressure decreased, and we decreased ultimately venous return. So now we go back down to the 10.
Extra pressure was too much, so bottom their blood pressure up.
We go back down to the 10. Your blood pressure stabilizes at 120 over 80. This is what we call optimal peak. We'd never go higher than that at this point because we know that we're going to run into oxygenation issues. Now we have to go up on the FiO2. We went up to 70%, and now the sats are 92.
I just want to say something about that rule. So the up to 60 and then the PEEP, I think it's more, you get more bang for your buck usually that way. It's more effective. Like, instead of, because if you're already at 60 and you can't get, that's a kind of a higher FiO2. So if you're not, their sats are still low, you're going to get better results with increasing a PEEP because they're already having severe oxygenation issues, like the O2 is not making it in for some reason. So I think that's why that rule is, like, if you're on 60, that's a pretty hefty amount if you're 21's room air and you're getting no result, then you better change your thinking to PEEP, and then worst case you can come back to the FiO2. But I mean, in a saying, you'll get more bang for your buck. If you're already at 60 and you're not getting anywhere, then you gotta look somewhere else. Don't keep looking at the FiO2 like, keep putting it up, keep putting it up. What are you gonna get from 87 to 88? You know, you're really not gonna make much leeway, so you have to change your thinking about how you can.
You tried it though.
Yeah, but that's why I think that cutoff of 60 is like,
Yeah, because I think that's
excuse me,
that's
like
when
let's
the
think of another way
association
because
curve
this
comes
isn't
in.
working.
Yeah.
So your same patient
That's-
who's on CPAP of 10, 70% FiO2, sats of 92, we just drew a blood gas. 733, 59, 65, 26. So what should I be doing now? What is the problem?
What'd you do?
We're in acute respiratory
Respiratory
acidosis.
acidosis.
Do I still want that patient in CPAP,
No, you
or
want
do I
BiPAP.
want them in
BiPAP.
BiPAP?
Bypass.
Right. Okay, so what are my starting, what does my IPAP at least have to be above? If the patient's still on CPAP of 10, what does the IPAP at least have to be above?
Above 10.
Above 10,
10.
right? Okay, because if I just put him on 10 of IPAP and 10 of EPAP, exactly, we're still on CPAP. So what do you guys want to try?
12?
12?
12 over 10, what's the difference?
It's too slow.
Normally, to be honest, you see at least a 5 centimeter difference.
Okay.
At least.
15.
Because you need to let them exhale a little bit.
Yeah.
The extraterrestrial, the extraterrestrial. That's the point of BiPAP.
Okay.
So you got to have a little bit of a difference so that it cycles from this.
And am I worried about this PO2? Because we're at
Well, you're gonna adjust
the 60-90 rule here. So when your PO2 is in the 60,
It's
your
a
SPO2
venous
is usually
blood
90.
gas, right?
But you know, we're 60, 92. We're at CPAP of 10 with 70%. But now let's try BiPAP. 15 over 10, 70% FiO2. Okay, get our ABG. We'll use
You helped me.
improving. So it's getting better.
We're getting better,
Yeah.
but are we normal?
No.
No.
No. Maybe the patient's tidal volumes were 250.
Or how long have they been on it? Because you're getting there. So, I mean, if it's been 20 minutes,
Maybe give them a little bit
Give a
longer.
little bit.
because they're close. I mean, you're getting there. You're
That's
seeing
what I was gonna
improvements.
ask,
But
how-
if it's only 20 minutes, don't like be trying to, you know. I
If
don't
it's been
know.
2
It depends.
hours?
Yeah. Yeah.
But
So
if the
it
blood
depends.
pressure's gonna go up because you put too much, it would happen within the 20 minutes usually. So if you
Oh,
know,
the blood. So we didn't change the EPAP or the PEEP.
No, I'm sorry, I'm jumping back to the one before. When we
Okay.
increased it to 15, it was too high. We had to lower it again
Okay.
when the blood pressure.
Yeah.
That would be, you'd see that within the 20-minute range.
Oh, yeah.
Yeah.
Their blood pressure drops.
Yeah.
Yeah.
But let's
So you
say
have to keep
same
monitoring
patient,
because
right?
who knows, it may be caused by something else.
All
that
of a
they're-
sudden they started vancomycin. The patient had pneumonia. Whoa! Holy moly! Let's say we left him on for a little bit longer.
Oxygen toxicity.
So you said it fast.
Sorry.
What? No, I just didn't know if everyone heard it. So what? The change there. So what she said before, you said that the problem ended up being a pneumonia, and they started an antibiotic called vancomycin. So that's the change is coming now. So are they getting better or worse?
Hang on.
Oh, sorry.
Is that
40?
9?
Yeah, 74040. Sorry. But their PO2 is 365. They're comfortable on BiPAP, and they're responding well to it. But now their PO2 is 365, and their sats are 100.
You knock out the hypoxia.
So okay. So what do you want to do after that?
You lower down the oxygen. You
Okay,
pull
yeah.
it down.
So they're on 70%, right?
Yeah.
Okay, so I put them down to 60.
Because remember the rules.
Mhm.
So it's so back to the other way is 2.
Is that if you usually go in like 10?
I usually do, yeah.
Yeah.
So would
go
you come down
more.
on the pressure first rather than the FiO2? If we're going backwards from the rule,
Yeah, that's a good question.
is the
I
rule
would
go
say
both ways?
I would say decrease the PEEP because you can have more damage
Done by
hemodynamically,
yeah.
blood pressure,
Pressure.
venous return. You want to do the most invasive
Yeah.
first,
Mhm.
taking away,
Yeah.
and then less invasive.
So
at
the
this
rule
point,
would exist going backwards
So you're
too.
still doing the
So-
step down.
You'd come off the
In
pressure
this
first.
case, do you start low or you just go down from 10 to 10? Or you start all
on the
over?
CPAP, these increments, I usually go down by 2 centimeters of water, and with the FiO2, usually 10%.
Yeah.
Okay.
But, you know, that's never every case. That's
Yeah.
just like normal-ish. But nothing's normal in this field, guys.
I know.
So
There'll
maybe
always
we
be
can come down
exceptions to the rule.
to our CPAP of maybe 8, right? So now we've come down to our, so now we're on, I'm getting lost here.
I know.
Oh, so we were 15 over 10, so I'm going to come down to 15 over 8, right?
Do you have an eraser?
60%. I do.
Oh. Erase some of that writing then, so you can continue this thing.
You guys
Too
got all
busy,
this stuff?
yeah. Too busy for me. I'm getting lost too.
Jeez, guys.
There you go.
So 15 over 8. Now my ABG. An hour later.
Oh, so they're not on CPAP. I'm confused.
What?
Are they on CPAP or BiPAP?
What are they on?
Oh, you did switch to the BiPAP, okay.
Sorry, it's confusing.
Yeah, I'm sorry, I was trying to
15
find,
over
because I was
10,
looking
yeah.
at the CPAP from the ABG, so.
15 over 10 was getting more
Got it.
normal, so we
Got
left
it.
them for a little bit.
Got it.
So
And-
we came down on the EPAP, which now has increased our ventilation because we went from 5 centimeters of water in between the two to now 7 centimeters of water in between the two. Are you guys getting this?
Yes.
Yes, this is.
Are you
This is
sure?
good.
Yes.
This is
Are you
good.
positive? Are you
Yes.
sure?
Yeah.
Speaking for myself.
If anybody's having difficulty,
I was
please
just
let me know
confused
because I
on
can
where
give
we
you
were.
whatever example you want.
We got this.
But you're getting it. That these two numbers, the bigger the in between the numbers, the more ventilation you're going to have, and it's going to affect your blood gas, right? Okay. And then this number is going to affect your oxygenation. But if you go up on this, you got to go up on that usually. And if you go down on that, you usually got to go down on that.
Yeah.
How down can you go? Up, I know you say have to be
Can
5.
you go?
The bottom
Usually,
number is usually no less than 5.
5, okay.
I think the
5 is
machines
what
go
you
to
have.
4 at the minimum, but we've never seen
Four.
4.
They don't really need it at that point. Take them off. You know what I mean? If they're only on 4 CPAP and it's
Yeah.
not for obstructive sleep apnea and they haven't had a sleep study, maybe a kid might need 4 CPAP if they had, like, childhood obstructive sleep apnea. But if they're down to that, then their body pretty much has, you have 5 of anatomical PEEP. So you just remove it at that point, depending on their blood gas. But if that's all they needed,
They don't need it.
Do you think you all
Take it
have
out
a
of it.
fair understanding of CPAP and BiPAP?
Yeah.
well, this
A
is
good introduction.
yes,
Yeah.
yes, still love it. I mean,
Yeah.
And you'll see, like on our V60s that we have, that our BiPAPs actually do a lot for a backup respiratory rate. Not to confuse you with the patient has to be spontaneously breathing.
For
They
both of them.
still should be spontaneous breathing. If my patient isn't breathing, am I going to slap them on the V60 with a backup rate of 12? No, what am I going to do? I'm going to call a code and I'm going to back masker, not putting the patient on BiPAP.
all the backup rate is it's going to cycle into that higher pressure, however many breaths you set per minute. That's all. But that doesn't mean it's going to make you can push all the air you want at the patient. But if they're
If
not
they're not
having
Not breathing.
it doesn't
It
matter.
doesn't matter.
So they have to be actively breathing,
Oh, yeah.
spontaneously
CPAP,
breathing,
BiPAP.
and then if they're not, they're on the ventilator. The BiPAP is called pressure support.
Sure.
Is that
Yeah.
what you're saying?
But we use pressure support as a form of weaning here, not to confuse
You'd have to be spontaneously breathing on the vent to do
Two.
pressure support.
Yes. Otherwise, you'll
You're
go
still
into
breathing in this
apnea.
setting.
Okay.
We won't even get into that because it's just going to confuse the crap out of you guys because you guys haven't even gone into
Yeah.
vents
Bottom
just
line is
yet.
spontaneously breathing.
And you should be spontaneously breathing. And also, always look at your patient too. If Christina's only pulling a tidal volume of 200, it doesn't necessarily mean that it's just because I have to go up on the iPad. Is the mask leaking? Is it appropriately over her face? Because more times than not, the mask is like over here or down here. Okay? And if I'm like Nurse Mellissa coming in, I want to give Christina her meds. Am I going to lift the mask up, give her her meds, and put the mask back over her face?
If you're a nurse, you will.
Yes. Why wouldn't I do that?
They could choke on their meds.
Is
They
that-
can do it,
you're-
They can
Yeah.
aspirate it right into
Yeah.
their lungs. You got positive airway pressure just pushing, and now you're trying to swallow. Who's to say it's going to go in the esophagus? That air's going into your trachea, and so now you've potentially just
And
had
then you get into one
aspiration
of these
pneumonia.
situations. They sat not oxygenating well.
Oh yeah, and you're
And
like,
they
why?
sit down.
I
and
don't
you're
know.
Like, I don't. Everything was fine. Like, what happened? Like, and then you look at the computer. They got meds like 15 minutes ago, and then you go talk to the
So you
nurse.
have to-
Oh, well,
Crap.
she was kind of sleepy, but she needed her meds, so I just like, slipped it in the side, and I
No, you
she swallowed them.
completely remove the patient from the BiPAP, put them on their normal oxygen device. If they desat, they need their meds, put the BiPAP right back on. If Christina was nauseous, would I put her on the BiPAP?
No, because she's.
No. What if she vomited?
Yeah, two, that's
It's a lucky day.
Right. So what do you do in that situation? Your patient's nauseous, but they have a bad blood gas. It wasn't great.
Give them anti-nausea meds
You
and
can
wait.
do that.
Yeah, hold
You're
the
gonna
BiPAP.
call the doctor. You're gonna write a note.
BiPAP held, you have to call the doctor just in case something happens.
They might want to get a blood gas in the morning, but the second that patient is not nauseous, I'd be putting them on the BiPAP. Zofran is wonderful.
Yeah.
And we have a BiPAP next door, so put on Pat.